Good evening, everyone. My name is Pádraig Fleming. Thank you very much for joining me this evening, and thank you to OHI for the kind invitation. So, this presentation is entitled Ortho-Prosto Interface Not Getting It Wrong. Now, I always try to start with a little introduction about myself so that you know where I came from. So, I'm from a small village in the northwest of Ireland called Enniscrone. It was a beautiful place to grow up. We have a lovely golf course there. You can see a picture of it here, and a beautiful sandy beach right beside it. Unfortunately, on this particular day that this picture was taken, the sun was shining, but that was a rare occurrence in the west of Ireland. Unfortunately, it rains a little bit more than we would like. But it was a beautiful, beautiful place to grow up. Now, Enniscrone, as I mentioned, is in the northwest of Ireland, and I moved to study dentistry in Dublin in 1997, and I studied in Trinity College in Dublin. Trinity College, again, is a really, really nice place. It's right in the city centre, and I spent 5 years there studying dentistry. During my second year, I was fortunate enough to be awarded a scholarship, which entitled me to free rooms in university for 3 years, and also a free meal every evening. So my parents were very, very happy about that. They were less happy, however, given the fact that I was also entitled to a free pint of Guinness every evening as well, by virtue of being awarded that scholarship. But of course, I didn't drink that every evening. Now, I moved to London in 2005, and I've been based in Whitechapel, which is in the East End of London, ever since then. So Whitechapel is a really great place, really busy hospital that we've got here. We've a new dental school that was built probably around 5 to 6 years ago at a cost of around £78 million. So really fantastic facilities and a really vibrant place to work. Now, I also spend quite a bit of time working as an associate editor for a number of journals. So you can see four here. And I've also written some textbooks, including co-editing the seventh edition of Graeber's textbook, which we hope will be published this year as well. So obviously, I dedicate quite a bit of time to academic work and to writing. And I guess I could potentially be accused of being purely an academic and not really being a wet-fingered orthodontic clinician. But actually, I love orthodontics and I do a lot of personal treatment as well. And one of the places that I work is actually in a cosmetic dental clinic. It's called London Smile Clinic, which is in the West End of London. And there I treat almost exclusively adult orthodontic patients. And it's many of the cases that I've treated here that I'll be discussing with you this evening. Now, when I started working in the practice, I was a little bit hesitant around whether I would actually enjoy it and even whether I should take the job in the first place. And I don't know if you've watched British television before, but there's some good British television programs, but a program that's probably less good is Embarrassing Bodies. It's a program which I think is now not actually being broadcast, but it was on a station called Channel 4 quite a few years ago. And in that program, they had a dentist called James. James was a fantastic dentist, a prosthodontist. And actually, he was based in London Smile Clinic. And he used to present quite a number of cases that he had been treating on that television program. Now, actually, those cases were typically adults and they quite often had crowding. But because of the fact that orthodontics wasn't really seen as being that accessible, maybe 10 to 15 years ago for adult patients, quite often they were offered only restorative solutions. So they quite often had probably slightly more aggressive prosthodontic planning in isolation rather than having careful joint orthodontic restorative planning. And I think things are quite different these days. So in this presentation, we're going to cover about 6 different things. And we're going to start off by discussing outcomes and experiences as it relates to planning adult orthodontics. So this here is Peter Greco. And Peter Greco is what I describe as a conscience of modern orthodontics. He writes a series of articles on a monthly basis which are published in the American Journal of Orthodontics. And basically they deal with ethical issues. And in this paper here, what Peter talks about is some of the decision making that underpins adult treatments. And in particular, whether first of all we should tailor the appliance purely to the patient, or maybe whether it should be a two-way conversation based around our knowledge as clinicians, but equally being mindful of what patients might be willing to tolerate, particularly as adults. Similarly, he also discusses how invasive we ought to be in achieving the very best outcomes for our patients. So really he's suggesting that there is a balance to be struck between the potential benefit of orthodontic treatment, the additional risk that's required, particularly for trying to achieve a certain type of outcome, and how to balance that difference based on the level of invasiveness that perhaps we should subject adult patients in particular to. And I think that's important because clearly as orthodontists, we have standards that we really want to meet. And I think this is certainly a good thing. We have to have a yardstick for which we aim in most, if not all, of our cases. And the one that I guess we're all aware of as orthodontists is Andrew's 6 keys to occlusion. So essentially an ideal occlusal outcome. Unfortunately, however, we know that patients think quite differently to us. And if we're to survey patients, which is something that we have done, particularly adult patients, what we've identified is that things like the efficiency of treatment is quite important to them. So in particular for adult patients, they seem to see, for some reason, a psychological barrier of around about 12 months as being the most that they would be willing to have appliance-based treatment for. However, crucially, when you ask them, is the efficiency of treatment or the outcome that you achieve more important? Well, unsurprisingly, they will say, actually, I want to achieve the outcome. And that creates a slight quandary for us. How do we maintain the best possible outcomes for our patients, but do so relatively efficiently? So it is a challenge. Now, this is another editorial. This was published by James Vaden, again in the American Journal of Orthodontics. And what he's suggesting here is that ideally, we really need to know about our predictability as orthodontists. So we want to know, if we treat someone, how predictable is it that we will achieve a really good outcome with limited risk or detrimental effect? And I suppose the best way of doing that is perhaps by building a registry on a national basis of the cases that we are treating. But that's quite a lofty ambition. And Peter and James here recognizes that actually that may not be feasible. The very least thing, however, that we should do is to try to evaluate our own predictability within our own practice settings. And I've tried to do that. I've tried to take James Vaden's advice on board. So this is an example of a subset of patients that I have debonded in my own practice, which as I mentioned, is essentially adult-based. So for example, over a 6-month period, I debonded 53 patients. You can see that the mean treatment time was relatively short, so less than a year. And the treatment time ranged from 4 to 23 months for those patients in whom I removed appliances. If I look in a little bit more depth, what you'll see here is that the majority of my patients had labial appliances. All of these had ceramic appliances rather than steel appliances. Some had lingual, some also had aligner therapy. What you can see is that the treatment time for all 3 groups was actually pretty similar. That may relate to case selection, so perhaps I'm treating slightly milder cases with aligners and possibly even with lingual systems. Equally, I also identified a need to undertake further continuing professional development when it comes to aligner therapy, because in my hands, I required, in 7 of those 15 cases, fixed appliances to detail the outcome to the standards that I think I would be happy with. And I placed fixed retainers in all of these patients, and one of those detached over that time period. So again, if we focus on this idea of risk and benefit, but also focus on the outcome and the process as it relates to adult orthodontics. When I'm planning my treatment, I think about 3 pillars. I think about health, stability, and aesthetics. And I think this is absolutely key. So in more detail, just to give you an example, if I'm treating a patient, for example, with a large overjet, I will think about How to reduce that overjet? Will I do it by, for example, retracting the upper incisors purely? Will I do it by protracting the lower incisors in isolation? Or might I decide to do a combination of both of those tooth movements? How would I decide? Well, what I'm thinking about is, what is the health implication of retracting the upper or advancing the lower? In particular, is there a periodontal implication, for example, by proclining the lower incisors significantly? Similarly, do those relative movements have an implication in terms of the prospective stability of treatment? And similarly, how will the relative changes affect the aesthetic outcome, both in terms of dental aesthetics, but also facial aesthetics? So really, really important, I think, to underpin any of the treatment planning decisions that we make in orthodontics. However, in particular in adult patients, I think that's even more important, because we know adult patients have quite often had quite a bit more dentistry. They also have quite often a less perfect periodontal support. So they may have a thinner phenotype, they may have pre-existing recession, and they may have pre-existing or historical periodontal disease as well. And all of these considerations are important when planning our treatment. Similarly, we need to be mindful that adult patients quite often don't relish the prospect of wearing appliances. It can, yes, on a transient basis, but it can affect their quality of life for the duration of treatment. So therefore, I am thinking about doing my treatment in a realistic time frame to reduce the risk of that iatrogenic damage, but also to minimize that adverse impact in terms of quality of life. So let's look at an example. So this is a patient that I saw in my practice. This is not, I hasten to add, a patient that I treated. So this was the photographs that this patient showed me that were taken at her initial consultation prior to commencing her orthodontic treatment, which actually took place in Spain. So as I said, these are the baseline pictures. Well, what could I see here? I could see some crowding of both arches. I could see imperfect occlusal relationships. So there was an increased overjet. There was a reduced overbite. Okay. And there was some class 2 relationships as well. What about the dental health? Well, that surely would have been of concern. You can see there was reduced periodontal support. There was a history probably of moderate periodontal bone loss, particularly around the lower incisors. There was also a very heavily restored dentition. Okay. So they were the baseline records. Now, when the patient came to see me for the first time, this was what the situation looked like. They had been undergoing orthodontic treatment for 11 months, involving a course of aligner therapy. A course of aligners involving, I think it was 82 aligners had been planned. The teeth looked like this, so the alignment had improved a little bit. You can also see that some spacing had been created in the upper posterior region. Why had they done that? Well, they'd done that, I think, clearly to distalize the upper posterior teeth, potentially to correct the posterior relationships from class 2 to class 1. They're also likely, certainly, to cause some advancement of the lower incisors in the process by virtue of running interarch elastics. Okay. However, I guess there were some signs of improvement in terms of the posterior relationships. What else did I find? Well, also I found, unfortunately, that the lower incisors were all grade 3 mobile and the upper incisors were all grade 2 mobile. Okay. So actually this patient had very significant adverse consequence by virtue of their orthodontic treatment. Why did it happen? Well, I think it happened for two reasons. One, because they probably failed to stabilize the periodontal condition before commencing treatment. But secondly, I think the treatment planning there was too aggressive. They could simply, given the degree of pre-existing compromise, I feel, have made a very simple decision to align the upper and lower arches, accepting the imperfect posterior relationships and accepting a slight residual overjet in that particular case. And that really, to me, kind of highlights the importance of a recognition that we are dealing with a biological system when we undertake orthodontic treatment. We need, therefore, to be quite flexible in how we plan adult cases in particular. And we need to balance the potential benefit of treatment versus the possible risk. So really, my kind of take on this is that we should consider ourselves to be diagnosticians who are managing a biological system rather than purely technicians who are slavishly trying to achieve those ideal relationships, particularly, I hasten to add, in adult patients who may have pre-existing periodontal or restorative compromise. So how do I approach the management of adult patients? Well, first of all, as with any other group of patients, we'll identify a problem list, okay? And from that, clearly, we will identify what we want to correct. Now, in adult patients, quite typically, my wish list will involve correcting everything. However, like that previous case, I do think there are certain scenarios in adult patients where we need to think about perhaps accepting some of the occlusal issues. And between us, provider and patient, as Peter Greco suggests, I think we need to develop common and clear aims which are clearly understood by our patients. So how do we manage the process? When we're managing these patients, quite often with compromised dentitions, how do we do it? Well, I like to think that these days in our practice, when patients present with crowding as adults, they will, regardless, obtain an orthodontic opinion. Why is that? Well, hopefully it's because orthodontics is now more accessible, as I'll go on to discuss, by virtue of some of the things that we do. But equally, it's because we know that with good joint orthodontic restorative planning, we can undertake, I think, much better correction, giving much better aesthetic outcomes, but also doing so in a more conservative manner than we could historically. And we will plan these cases together. And ultimately, as an orthodontist, I will rebook the patient to see the restorative dentist, typically 4 to 6 weeks prior to a point where I think I'm likely to be completed their treatment. The restorative dentist at that point will clearly look at the alignment of the teeth in terms of both intra and interarch features, but also look at important points around gingival heights in particular. So we do see the odd, very, very straightforward case in practice. So some of the simple alignment cases that we might see, can be very, very straightforward. Literally 6 months or so of alignment, in adult patients. But these typically are a rarity for me, and quite often I find that these patients are getting married and want some quick fixes prior to their wedding. However, quite often we need to undertake comprehensive treatment in adults, and that brings its own challenges. And I have to say that I plan these patients slightly differently as adults to how I might were they seen as adolescents. So let's look at an example. So this is an adult patient, a skeletal 2 pattern with fairly average vertical dimensions. So if we look at the occlusion, you'll notice some issues. So there's lower arch crowding, particularly around that lower left canine. There's a retained maxillary left primary canine, and there's also absence of the lower right canine. The molar relationship on the right side is class 3, the molar relationship on the left side is class 1, and the upper midline is essentially coincident with the facial midline. So you can see radiographically, the upper left canine is present. It's impacted, and that upper left primary canine is retained. The lower right canine has previously been extracted. So, how will we plan this patient? Well, first of all, we will develop clear aims. And my aims in all of these cases will not be purely inter-arch aims. They will be both intra and inter-arch. So I will be making a decision around where I want to place the lower incisors, where I want to place the upper incisors. The occlusion will follow. But I'll also, in adult patients in particular, think about the process of treatment because this matters to them, as I've discussed already. Now, this patient actually was joining the army, so I therefore needed to be efficient. She needed to have her orthodontic treatment undertaken relatively efficiently so that she could progress with her career. Now, I felt that she required extractions, and in order to achieve the best outcome for her, I needed space to align the lower arch, to avoid a lower midline shift, but equally to avoid either advancement or retraction of the lower incisors. So essentially I needed space to align the lower dentition without changing either the lower midline or the anterior posterior position of the lower incisors. Because I wanted to undertake the treatment efficiently, I planned typically in these cases to undertake relatively early space closure so that I get more rapid space closure in adult patients. So as I mentioned the problems, we've got the impacted upper left 3. We also had a missing lower right canine, and we had that crowding on the lower left side. The upper midline was correct. So what did I plan? Well, I planned fixed appliance based treatment. I made a decision to remove the upper left primary canine and also the impacted upper left permanent canine, as well as the lower left second premolar. I planned to maintain the upper midline. Okay, now to do that, I knew I would have a challenge, okay, because I was extracting on the upper left quadrant in isolation. I did have some space in the upper right side distal to the upper right canine, which I knew would help me to a degree. I also wanted to maintain that lower arch length, so therefore I extracted that lower left 5 rather than the lower left 4. I felt that the lower left 4 would give me an excess of space. Similarly, I knew that if I took the 4, I would have less scope for use of class 3 elastics. And class 3 elastics here on the left hand side were quite important for me because I knew I would have a challenge in avoiding iatrogenic movement of that upper midline to the left side. So the class 3 elastics would help me to protract the upper left posterior segment as I closed that space in the upper left canine region. So let's look in more detail. We removed the upper left canine. We also removed, as I said, the upper left primary canine and the lower left second premolar. Now we get our appliances on, okay? Now what you might notice here is that this is the bond up appointment. I've placed light elastomeric chain at that appointment, okay? So I'm actually aiming to commence space closure very soon after the extractions have been undertaken. This is not something that I will do in adolescent patients. I typically do wait until I'm in much more rigid archwires. However, in adult patients in particular, what I want to do is to avail of that fresh extraction site, that potential regional accelerated phenomenon, so that I can start some space closure early. Now, obviously, if I do that on light nickel titanium wires, there is a risk, in fact, a likelihood that I will get some unfavorable iatrogenic effects. I therefore use very, very, very light forces. So you may notice that I've got extra links of power chain in this extraction space. I will also always ensure that I have bonded the lower left second permanent molar. I'm not running space closing mechanics to the terminal molar in the lower arch. If you do that, I do think that you risk unwanted rotation. Okay, so I'm running my space closing mechanics to the first molar only. So we place the elastomeric chain, we place the appliance quite clearly. You'll notice I've omitted that lower left lateral incisor. Now the patient comes back 8 weeks later. Things look very, very different. So what you might notice is that lots of space has already closed. So I've probably closed already about 50% of the extraction space. I've now got room to place an attachment on that lower left lateral incisor. Okay, so from here, it actually is a very, very straightforward task just to complete this case. And actually, the overall treatment time here is not significant. This is an adult patient, an extraction case, and I've completed that treatment in less than a year. So how have I done it? Well, I've done it, I feel, by treatment planning very, very simply. I've planned to maintain that pre-treatment molar relationship, class 3 on the right side, class 1 on the left. I've extracted the lower left 5, not the 4. Easier space to close, less issues around anchorage management. I've started my space closure early using that fresh extraction site. That I do think expedites the space closure. I've also taken the upper left 3 rather than the upper left premolar. Okay, and that's important. Why is that important? Well, if you look at some research on this, this is a paper by Becker and Chausu, who are the world leading experts on management of ectopic canines. And even in their expert hands, what they've suggested is that ectopic canines do sometimes fail to erupt. As a rule of thumb, they've suggested that in adult patients over the age of 30, 30% of ectopic canines fail to align. So there therefore is a 30% risk that in a patient like this, actually, you might have complete failure of your treatment. Okay, so therefore in an adult patient like this, with a space requirement in a quadrant with an ectopic canine, I will quite often give due consideration to extraction of that tooth. So let's look at another patient. Again, an adult patient. Okay, so this patient had a significant overjet. You can see they have class 2 molar relationships on the left side. Class 1, close to class 1 on the right, probably quarter to half unit class 2. Now this patient had seen 2 orthodontists previous to me in London, and both of them had suggested that premolar extractions were required in the upper arch in order to correct the class 2 and to achieve the best outcome. Okay. Now, I saw the patient and I would not consider myself to be a non-extractionist. I try to judge every case on its merits and make the right decisions by patients. However, actually, I felt that avoiding extraction in the upper arch here would be in this patient's benefit in both the short and long term. Now, the challenge clearly, if we're avoiding extractions, is ensuring that we get a perfect outcome despite that decision. And that dictates that we need correction of the molar relationships. Okay, we have to clearly correct that molar relationship on the left side to class 1 in order to end up with class 1 incisors. And to a lesser extent, the same applies on the right side. Now, why do I think that it's better to treat this patient on a non-extraction basis in the upper arch? Well, there are 2 reasons for me. One, during treatment, I think if we extract bicuspids in the upper arch here, space closure is going to be difficult. Why is that? Well, this patient, first of all, has a relatively deep overbite. We know that space closure is more challenging in these patients, particularly as adults. Secondly, there wasn't much crowding in that upper arch, very, very little. So to me, this is not an underlying crowding issue. This is a class 2 issue. And therefore, space closure is going to be lengthy because when we extract, we will not relieve or reduce that extraction space by virtue of relief of crowding. So we will have a lot of extraction space to close. So that makes the treatment itself challenging. Now, finally, in adult patients in particular, particularly who have limited crowding at the outset, I do think that space reopening is much, much more likely during the retention phase or the post-treatment phase. So actually, I think that would alter my approach to retention management. I would probably be looking at a sectional bonded retainer posteriorly as well in this patient had I made a decision to extract. So that again is a further undertaking for a patient and a further challenge for me. So therefore, actually, I think the right thing to do here is to treat the patient on a non-extraction basis. So how do we do this? Well, in this particular patient, because I didn't have much scope to advance the lower incisors, what I did was to make a decision to primarily correct this class 2 with upper arch distalization. So again, there's various techniques for doing this, things like Benny sliders, for example, involving bespoke palatal appliances. The way that I tend to do this these days, though, is by using infrazygomatic crest screws. I supplemented this with a minimal amount of class 2 traction as well, as I had limited scope to advance the lower incisors. So the beauty of these infrazygomatic crest screws really is that they are extra alveolar. So we can site them in an area where hopefully we can distalize without being concerned about the fact that roots of teeth that we're distalizing will begin to interact with that screw because it is extra alveolar. So ultimately we place the mini screws, we get some distalization with quite heavy forces. You're looking at, force levels of the order of 350 to 400 grams here in order to distalize these posterior segments. So again, this is not rapid. This is a type of treatment that will take me time in adult patients. And it's important that patients, again, to be fully versed both in terms of the outcome and the process, expect that. So as I said, this patient commenced, I think, in about February of 2020, was completed in December 2021. So a course of treatment in not much less than 2 years, really. So again, as I mentioned, when you're doing this, full upper arch distalization, this is a challenge. Higher force levels, I would say, are required to do this. And if you want to learn more about this, without question, the person to read or to follow is Chris Chang here. These are some pictures from a paper of his, which again illustrate the technique around placement. So typically we're looking at placing these in the upper first to second molar region. We tend to orientate near perpendicular to the alveolus initially before reorientating at 50 to 60 degrees, certainly with Chris Chang's technique. There are, however, alternatives. And typically, again, we are looking at longer screws, again, with most systems, and higher torque values than we would normally use with some of the alveolar implants that we tend to use as mini screws in orthodontics. So again, a really valuable technique in adult patients. So they were two relatively conventional, cases with limited restorative impact. But let's start to look at how we manage adult patients with pre-existing periodontal compromise, wear, and prosthodontic needs. So this adult patient was relatively young, 38. She, as you could, I think, work out from these pictures, had a history of pretty severe periodontal disease. And she had related aesthetic concerns. So she had quite salient black triangles here, and she wanted aesthetic improvement. She also had a lower dental midline shift, and that was related to previous loss of a lower premolar tooth. Now, when I'm planning this sort of case, what I will be aiming to do is to essentially close the spacing that, for example, you can see in the upper right quadrant, as well as the median diastema. I also would plan to reshape the contact points so that we can improve these to try to encourage some better gingival infill to improve the aesthetics. However, I would also plan some direct restorative input in order to improve the final aesthetic outcome. Okay. Now, I mentioned this patient had pre-existing space in the arch. Okay. I know I'm going to do some contact point reshaping. However, what I will plan in a case like this is space closure in the first instance. Then I will start the recontouring, okay? I will not generate more space by undertaking IPR before I've closed the initial spacing within the arch. Why is that? Well, again, this is a patient with severe periodontal disease. Okay, what I do not want to find is that for whatever reason this patient cannot tolerate the appliances or has an exacerbation of the underlying periodontal condition, and find that I have to stop the treatment and actually leave them in a worse position than when they started off by having created more space. So I will close the space, then I will start my reshaping, and then close that space that I have generated. Okay. So you can see the progress of this particular case. I am undertaking this IPR. I will do it sequentially, and you can see the reduction in the size of these black triangles. Then at the debond appointment, what I did here was to have my restorative dentist commence some bonding in the gingival regions here to improve the gingival appearance. And ultimately, we've obtained, I think, a very nice outcome with a combination of orthodontic space closure, reshaping of contact points, as well as some direct composite buildup. What you may also notice, however, is that I've not corrected the lower midline. Okay, again, that's an orthodontic compromise, but I would argue that that is the right compromise to make in this patient. Okay, if I wanted to correct that lower midline, I would have had to generate some more space in the lower right quadrant. I probably would have had to create more space in both upper quadrants as well. And certainly I would have had to manage my anchorage very, very carefully. So again, that would have required a lot more intervention for this patient, a lengthier course of treatment, and therefore more associated risk. So I think that this was the right compromise for this particular patient. Now, can we undertake IPR on all of our patients? Well, I guess in theory we can. But actually, there are certain patients in whom IPR is much more appropriate. And I would say, fortunately for us, some of the patients who really need IPR, like adults in particular with thin periodontal phenotypes, as I will talk about, and also pre-existing recession, these are some of the patients actually in whom IPR is most predictable and most easy to undertake. It's adolescents, particularly with long contact points, that in particularly are gingivally positioned. These are the patients in whom IPR can be quite a challenge. Now, my patients quite often ask me, is IPR a safe thing to do, Pork? Well, I would say it really depends on how it's done. Okay. And I would like to think that it's pretty safe in my hands, but at the same time, you have to undertake it carefully. There is some good evidence there from people like Bjorn Zachrisson, for example, that 10 years following orthodontic treatment involving IPR, there has been no significant increase in caries risk and risk of demineralization or indeed of periodontal problems. But that's by Bjorn Zachrisson, who we all know is a fantastic orthodontist. So it's important that we know our safe limits. So again, this is a slide that I've put together just to illustrate some of the safe limits that we might have. And what you can see here is essentially an estimation based on pre-existing research of how much enamel we have in certain areas. Okay. Now, in particular, if you look at the lower incisor region, this is where we've got least enamel. So around about 0.7 millimeters per surface mesially on the lower incisors. Distally, a little bit more than that, so around 10% more. And as we move posteriorly, we have typically around about 10% more enamel per tooth until we move to the second molars. A little bit more as well in the canine region. So again, a useful guide to have to help us to plan our IPR. Are we aggressive or conservative when we undertake our IPR? Well, again, if we look at research, this study here has shown that actually we undertake probably around about 50% of the IPR that we actually plan. And this relates to Invisalign or aligner type treatment. Okay, so we tend to be quite conservative. So how do I undertake my IPR? Well, I have to say that this is something that I have changed numerous times in my career. So here you can see an example. This is how I tend to undertake my IPR these days. So what I use initially are flexible strips. Historically, I wouldn't undertake my IPR until the teeth were more aligned. Okay. However, these days, what I will do is start my IPR because I'm using flexible strips earlier in treatment. So I might do it at visit one. Okay. I will start with single-sided strips, which are between 0.22 millimeters and 0.32 millimeters in thickness. I'll then use two strips together, so I'm increasing the amount of space that I've generated. Okay? So that will basically break the contact point for me. Okay? Now thereafter, I'll be happy to use something like a disc to finalize my space creation. So again, obviously we created a limited amount of space with our flexible strips. We've got room in which we can use our disc very easily. And again, a very simple process for patients, relatively pain-free in the process. So again, that's that particular case that I showed you. So again, we flatten the contact point here. We therefore have less space that gum has to fill, and hopefully we can get an improved gingival appearance as a result. However, quite crucially in these patients, I will not advise them or promise them that full closure of black triangles is something that I'm likely to achieve, particularly if they have a thinner periodontal phenotype. Okay. Now, periodontal phenotype is something that we talk about more and more these days. We're more and more aware, I think, of the interaction between orthodontics and periodontal health and potential bone loss and recession. So how likely are we to introduce problems during our orthodontic treatment? Well, again, this is a nice rule of thumb here. So this is based on cone beam CT based data. Okay. So essentially in this study, what the authors did was to evaluate using cone beam the relationship between lower incisal proclination and vertical bone loss. Now what they've suggested is that if we procline lower incisors by around about 8 degrees, there is a 50% risk of causing around about 2 millimeters of vertical bone loss in the lower anterior region. Now, I would say that it's hard to predict on an individual basis how much risk our patients will have. However, when we're dealing with patients who have thinner periodontal phenotype to start with, who, for example, might have an increased lower anterior facial height, I think they're much more likely to experience adverse changes during treatment. Okay. Now, what this diagram again is illustrating, and again, this is more widely available, for example, on my Instagram accounts, is just how tenuous the cortical plates are in certain areas. And in particular, I'd ask you to focus on the interfirst premolar region. We do not have that much scope in these areas to expand. The cortical plates are quite thick buccally. This is the upper, and you can see in the lower, we've probably got even less scope based on this cone beam CT data. So we need to be careful around where we're positioning our teeth. Again, I get back to this concept of health, aesthetics, and stability. So let's look at an example. We see a patient like this. This is a patient that I treated a few years ago. So she had a very, very thin scalloped periodontal phenotype. She had lower anterior crowding. She also had some class 2 issues. She wanted alignment of her teeth and a better dental appearance. I'm aware that she's class 2 on the right side. Should I try to correct that? I'm really not convinced that that's the right thing to do on this particular patient. Should I even treat this patient? Is alignment, for example, of the lower anteriors the right thing to do? Is it safe? Well, again, I think it's hard to predict these things. Certainly the advent of cone beam CT will help us. Okay. However, what I also tend to look at is the gingival appearance. So if I look, for example, at the lower incisors here, one thing that is in my favor is that in the lower right central incisor region, I do have some tissue labally. I don't have labial recession, while I do have lingual recession. Okay. Similarly, if I look at the other incisors, I've got labial recession on them, but I actually don't have much in the way of lingual recession. So there is some tissue that is vascularized in this area. Okay. I just have to be very, very careful around where I position the teeth. If, on the other hand, there was significant recession both labially and lingually, well, that's when I would get very, very concerned, and I may make a decision not to treat that type of patient. Now, again, if we look at this case, what I did actually was to make a decision to remove the most compromised lower incisor based on a periodontal opinion. I removed the lower right lateral incisor. We undertook very, very simple orthodontic treatment. But again, this is a compromise. I've just made a decision simply to align these teeth, accepting a slight residual overjet with some upper anterior IPR in particular. But again, I have not compromised the periodontal support in this particular patient. So to me, this is the right type of compromise. Now let's look at a more subtle example. So this is a 2-div2, a patient with some crowding of both upper and lower arches. Okay. So again, there are some more subtle periodontal issues here. You can see some crowding of both arches. There was also hypoplastic maxillary left, first permanent molar, and there was a thin periodontal phenotype. You can see some fairly subtle black triangles in the upper anterior region in particular, but also in the lower anterior region. There were some gingival margin discrepancies as well, and some asymmetric wear. So again, these are things that we see all the time in our adult patients, and quite often they need some joint planning at the very least. So again, if we look in more detail here, if we look at the gingival architecture, well, I notice first of all, there's a discrepancy between the height of the central and lateral incisors. The central incisors are lower. Can I correct that relationship? Well, I probably can, okay? I can do some relative intrusion of the central incisors. Now, if I compare the lateral incisors with each other, again, we've got another issue. The upper left lateral incisor in particular is quite long, okay? Well, why is that? Well, actually, it's because there's a deficit of tissue in the upper left lateral incisor region. There is pre-existing recession there, okay? And I can't change that, particularly as an orthodontist, okay? Now, in the canine region, there's actually quite short canines as well. Again, that can be managed, okay? That can be managed, depending on the specifics of the presentation, most likely with some gingival recontouring. But again, these are things that we should be spotting in our adult patients. Similarly, there is uneven wear on the upper incisal edges. And again, this is something that we'll factor in to our tooth positioning. So we commence treatment on a patient like this. And what you'll notice is that I'm aligning the teeth. I've got quite a number of vertical bends in here, as well as some angulation bends to address, root position. What I'm trying to do is my very best to minimize any dark triangles in the aesthetic zone in particular. So I'm managing the angulation of the incisors in order to minimize this. Okay. I'm also undertaking some sequential IPR, again, in an effort, to get the best gingival infill that I can in some of these areas. How did I get on? Okay, well, I've got a reasonable orthodontic outcome. We've got a perfect class 1 occlusion, normal over jet and over bite. Okay. However, I haven't fully addressed all of the issues. Okay. One thing that's in my favor is that she's got a relatively low smile line, so actually I'm not overly concerned about that gingival mismatch that I highlighted earlier on, but that is something that we noticed at the outset that we knew could have been addressed should the patient so wish following orthodontic treatment. Similarly, restorative management of those black triangles is again a possibility. Actually, something that this particular patient did not want, but again, it's something that we should be highlighting to these patients prior to commencing treatment. They need to go in with a clear understanding of what treatment will involve. So that patient had some relatively minor wear. Let's look at a patient that had more significant wear. How will we manage this type of patient? So again, a class 1 occlusion. History of previous orthodontics. They've had loss of 4 premolar units. He's also got relatively diminutive maxillary lateral incisors, and he's got some localized lower anterior crowding, okay, as well as those tooth size issues. Now, this particular patient has made a decision that he does not want any restorative bonding. So he wants his treatment to be conservative. He doesn't want the hassle and the expense of maintaining restorations following orthodontic treatment. Okay. Now that presents a challenge for me. Okay, because I know if I'm not going to lengthen the upper left central incisor restoratively, I will have to even the incisal edges and accept a gingival margin discrepancy. Okay, is that reasonable in this patient? How do we work it out? Well, first of all, we look at incisal display at rest and unsmiling. And again, this patient did not have gingival exposure unsmiling prior to orthodontic treatment. So actually, I think accepting a slight gingival mismatch was a reasonable thing to do. Okay. Now, I had other challenges from an orthodontic perspective here. Okay. As I mentioned, he was keen to avoid restorative enlargement. Okay. Now, if I was to avoid the need for restorative enlargement to the upper incisors, I need to be very careful about how I manage my lower arch. Because orthodontically, what I cannot let happen is advancement of the lower incisors. If I do that, the lower arch lengthens. Coupling of the dentition will mean that actually it's going to be very, very hard for me to close that upper anterior spacing. So I need to have very clear objectives in terms of the positioning of both my lower and upper incisors before commencing treatment. And I will mitigate that risk of advancing the lower incisors. How will I do that? Well, I'll pre-plan my setup, the brackets that I will use in the lower anteriors to avoid, for example, advancement of those incisors. I will manage the mesial tip expression in my lower canines, again to avoid their advancement and similarly the advancement of the incisors. I'll think about the wire dimensions that I'm going into and I will plan for some IPR on the lower anteriors as well. How do we promote optimal positioning of the incisal edges? Well, I will do things like artistically position my brackets. So what you notice here, for example, on the lower left, central and lateral incisors, is that I've positioned these attachments a little gingivally in order to encourage their extrusion. I want to level the incisal edges. I'm happy to accept a slight gingival mismatch. And I will be planning some disking, certainly, on the lower right, central and lateral incisors. So again, we work through the arch wires here. You'll notice we've planned some progressive disking of the incisal edges during treatment here, and I've positioned my attachments artistically. We continue to undertake some local wire bending here as well, again, just to try to improve the relationship between the central incisors and lateral incisors. We look at the lower incisors, again, a similar process around extruding the lower left, central and lateral incisor, and also some incremental disking. So again, we make the right decisions from the outset, we manage the lower arch length, and again, coupling of the dentition is quite straightforward to maintain. Okay, and therefore space closure is quite easy to effect in the upper arch, despite having those relatively diminutive maxillary lateral incisors. Okay. So again, we knew we would have to accept a compromise here, but we've limited that compromise to the gingival level, not the incisal level, because this patient did not wish to have restorative bonding. Okay, so that's one way to manage wear. Okay, so purely really from orthodontic input. A different case here. Okay, so this patient again has wear. Why is there occlusal wear? Well, I would say quite often it is multifactorial. Okay, and this case is no different. So primarily this is due to intrinsic erosion, history of eating disorder, but similarly there is a class 3 incisor relationship and an occlusal element to this as well. Now quite clearly the upper incisors are short here. Okay, so we will need to create some interocclusal space in order to permit restoration of those upper incisors to build them to a more aesthetic dimension. Okay, so how will we plan this? The case is class 3. There is some lower arch crowding. Okay, so again, in a case like this, I've got to have tailored objectives. So I've got to make a decision. Am I going to advance the upper incisors? Am I going to retract the lower? Am I perhaps going to do both of those things? Well, in this case, I felt from an aesthetic perspective, I did have some scope to advance the upper incisors somewhat. Similarly, however, I needed to retract the lowers in order to prevent excessive advancement of the upper incisors during that class 3 correction. So again, I will plan my setup again to affect those changes. So I'll manage my bracket prescription in the lower arch. I'll manage my mesial tip expression in my lower canines. I'll plan for some lower interproximal reduction, as well as limited use of class 3 elastics, because I do not want to excessively advance my upper incisors. So again, by doing that, we hopefully simplify the treatment, we create the interocclusal space that we need, and we plan tooth positioning based on gingival aesthetics here. We want to try to improve the relationship of the tooth relative to each other at the gingival level. We can then hopefully reposition the teeth such that we can have restorative work done to hopefully restore these teeth to the perfect dimensions. Okay, and therefore in a case like this with an additive solution, i.e. combined orthodontic restorative solution, we shouldn't really have compromise in terms of either gingival position or incisal edge positioning. So let's look at another example. Really simple little case here. So this is a patient who presented to me actually only about 4 to 6 weeks having completed orthodontics with another provider. Now, the previous orthodontist had made a decision to try to level the incisal edges here, okay? And that's not unreasonable. But unfortunately, the patient felt that the gingival discrepancy was something that she didn't like. She wondered whether we could move this tooth orthodontically and therefore undertake some restorative treatment to restore it again to a more normal vertical height. So could we do it, okay? And is this type of change predictable? Well, yes, we can do it. And actually the orthodontics is very simple. Okay, so all we would plan in a case like this is simply bonding our attachments with the gingival margins in mind. Okay, so by that I mean I'm going to visualize the amount of intrusion that I will need of the upper central incisor. I will hope to get a one-to-one movement in terms of the amount of gingival movement I get associated with that tooth movement. So therefore, if I bond incisally to that level, I'm likely, I hope, to get the same amount of intrusion of the gingiva, okay? Unless the patient has a particularly thick gingival phenotype, okay? So we're bonding with the margins in mind, okay? So this patient literally has 2 adjustments. They did have a little vertical offset put in and steel wires as well. We managed to level the gingival margin, and then they have some very simple direct composite bonding to restore the anatomy. So a really simple change. Again, we're looking at no more than around about 3 months of orthodontic treatment to achieve this. Okay. So another example. Okay, so again, we've got a patient with, again, a mismatch between tooth size and again affecting the incisors. Should we go with the same solution? Is there one solution for all of these patients? Well, the answer to that is no. But how do we work out what is the correct solution for each patient? So if we look at this patient in more detail, well, first of all, she had crowding of both arches. She had a class 2 issue actually on the left side as well. This particular patient did not want to have comprehensive orthodontics actually. She was getting married. She simply wanted some alignment of her teeth. Okay, so she wanted me to undertake her orthodontics relatively efficiently. However, again, we try to highlight all of the specific issues to her before commencing. And one of the things that we noticed was this mismatch in height between the central incisors. Okay, so how can we manage that? Well, I guess one thing that we could do, like that first patient with wear that I showed you, is to accept the gingival margin discrepancy. Okay. A second is maybe to intrude the upper right one and to build up that tooth incisally. A third option might be gingival surgery to that tooth, avoiding build-up, maybe with some local disking on that longer upper left one. Or maybe we should look at a combination of both of those options, 2 and 3. Okay, but what's the right solution? Okay, well, if we look at this patient, what you'll notice in more detail is that if we probe, there's actually some deep pocketing around that upper right central incisor. Okay. Similarly, if you look at the anatomy of the crown itself, actually there is an enamel halo at the periphery. There's also translucency beneath that enamel halo. So that highlights that this tooth is essentially an unworn tooth. So therefore, really the correct solution for this patient is not an additive solution with maybe a direct composite. It's actually to try to level the edges orthodontically and to look at some gingival recontouring at the end of orthodontic treatment. Okay. So that's actually what we did here. Very simple orthodontics, just to level the incisal edges. She'd planned for a little bit of disking on the edge of the upper left one, and then some gingival recontouring. Now, what you'll notice at 6-week review is that this gingivectomy is relatively stable. This was done with a laser, and again, a 12-month follow-up, again, relatively stable. So I'm relatively happy with that outcome. Okay, so again, similar presentation, but different solution because of the specifics of that presenting problem. So let's look at more complex prosthodontics and how we facilitate orthodontic treatment and correction in these cases. So, I think as orthodontists, we need to be careful because we often see ourselves, whether it's in adolescent patients or indeed in adult patients, really as the people with the answers. And, sometimes in these adult cases, actually, we don't have all the answers. And really, when I look at a patient like this, she didn't want to have orthodontic treatment, actually. And most of her problems really were restorative. She had worn teeth, she had discolored teeth. Yes, she did have some imperfect positioning of the teeth, but actually she mainly wanted restorative correction. However, the restorative dentists that work with me know that if we're going to get the best outcome here, we need to relocate some of these teeth. So in particular, she's got a significant diastema. She's got quite a small upper right lateral incisor. She's also got gingival margin discrepancies. So if I don't approximate the central incisors aesthetically, this is going to be very poor. So I see my job really is just facilitating, optimal orthodontic or restorative correction. Okay, so again, a course of orthodontic treatment in her will be short because I'm just facilitating that restorative treatment. Okay, so I'm facilitating correction that otherwise maybe she wouldn't actually explore, or maybe would be too invasive for us to suggest for her. Let's look at an example and cover this a little more comprehensively. So again, an adult patient. So significant crowding of both the upper and lower arches. Okay. However, you look at her teeth and you think, actually, she's got significant tooth quality issues. You look at the upper incisors and actually it's quite hard to work out which teeth are they. Is that an upper right central incisor or a lateral incisor, for example? Well, actually it was a very worn upper right central incisor. So this lady needs some restorative management, okay? But also she has crowding, okay? And as well as having crowding, she's got a significant upper midline shift to the right side. She also happens to have a lower midline shift to the left side. Okay. So what would I plan for her? Fundamentally, she wants a makeover. She doesn't really want orthodontic treatment. She wants her teeth to look whiter and to look better, okay, more even. However, in order to get the best outcome for her and to do so in a relatively conservative way, we would have to have orthodontic treatment as part of her overall management. So when I'm planning her treatment, I'm planning to align the upper and lower arches. Clearly, that's a given. We will do that on every patient. I'm also planning to correct the upper midline. That to me is really important actually in these patients. Why is it important? Well, it's important because ultimately she will have very nice restorative work at the end of her treatment. She will have a vast improvement in tooth colour. Okay, if we don't correct the upper midline and she's got straight teeth, to my eye, that upper midline shift becomes more and more salient. Okay, so it's important we correct it. On the other hand, actually, I don't think that correcting the lower midline is that important. Okay, and fundamentally, we want to facilitate her restorative management again. So how do we do this? Well, basically, we treat her with fixed appliances. I manage the upper midline by using mini implants here to create some space on the upper left side to allow for some distalization of that upper left posterior region and associated upper midline correction. Okay, we treated her out with fixed appliances. We took just under a year to do this. Again, I bring her back to my restorative colleague. One of the things that he will look at is the gingival margin position. Actually, in this case, although there was a discrepancy, he felt that further orthodontics to intrude the upper right one, for example, was not required. He could manage that gingival mismatch himself. Okay. Ultimately, she then goes on to have restorative treatment. She had some local gingival recontouring, as well as some veneers and a couple of crowns as well. Okay, and ultimately she chose what I think is a very white color for her restorative work, but hopefully you agree she got a very nice overall aesthetic outcome. And certainly I think by addressing that upper midline, we have ultimately given her a much more aesthetic outcome. As I mentioned, we did not go to the lengths of correcting that lower midline. I just don't think the amount of intervention that would have required would actually have been warranted in her case. Another example, again, an older patient, 62, significant lower arch crowding, a missing lower right first permanent molar, deep overbite. You'll also see that she's got significant gingival margin discrepancy between these central incisors. Okay. You may also recognize that she's missing a lower incisor already, as well as having that significant crowding in the lower anterior region. So how do we manage a case like this? Well, again, if I think about how this might have been managed years ago, maybe it might have been managed with restorative dentistry only, okay? But I don't think that's the right thing to do. What we can do in a case like this is utilize some of that lower molar spacing to align the crowded lower incisor, okay? So we use fixed appliances, we utilize that space. I wouldn't, however, guarantee her that I could fully close that space. That may not happen in that lower right first permanent molar region, particularly in a 62-year-old patient with a deep overbite. Now, this patient actually happened to be very, very good at wearing her elastics, and I was able to fully close the space, okay? But fundamentally, we have now been able to align the lower incisor to close that lower molar space where others may have perhaps gone for a dental implant replacement. And really, we haven't compromised to any significant degree. Now, interestingly, at the end of her treatment, she had actually not planned a restorative phase to her treatment. She subsequently changed her mind. She did have, you'll notice, the gingival margin discrepancy between the central incisors. I therefore actually had to put an appliance back onto her for a very short period of time to reintrude that upper right central incisor so that she could then have a more aesthetic veneer done on that tooth. So ultimately you can see the aesthetic outcome, and again, hopefully we facilitate a more conservative solution and a more aesthetic solution for her by undertaking hopefully relatively efficient and predictable orthodontic treatment. So another combined case here. So this is a patient who had hypodontia, missing upper right lateral incisor, missing upper left canine. Also developmental absence of two lower bicuspids as well. So she'd had previous orthodontics in adolescence. She had subsequent relapse, and the dentist then made a decision to try to restore the missing upper right tooth. And as you can see, they have got a really tiny pontic in this region. Okay, so clearly very, very unaesthetic, and we would have to make a decision in a case like this. Do we look at reopening space for that missing upper right 2 and upper left 3, or do we space close? Okay, she had class 1 molar relationships. She also, as I mentioned, had previous she developmental absence of lower premolars as well. Now I made a decision in this case actually to go with space closure in the upper arch. Okay, so what I would therefore be doing is essentially protracting that upper right buccal segment and allowing for substitution of the upper right canine for the missing lateral incisor, and similarly protracting the upper left 4. Okay, now doing that again means I need to be very careful about how I manage my lower arch length. I cannot let those lower incisors come forward significantly. If I do, I will really struggle to close that upper space and to protract these posterior teeth in the upper arch. So again, it's about planning this from the outset quite carefully from an orthodontic perspective and setting up the arches based on your treatment objectives. So again, you can see hypodontia, we've got to make a decision, space open or space closed. We made a decision, as I said, to protract this upper right canine, to protract the upper left first bicuspid as well, and ultimately, undertake substitution of the canine for the lateral incisor, and again, converting the upper left first premolar to a canine. So again, we managed to do this relatively efficiently. Again, orthodontics over a period of around about a year or so prior to the placement of those veneers. So again, hopefully a very nice outcome, but facilitated, by having, clear objectives in both arches around, in this case, facilitating fairly predictable space closure in the upper arch. Another case here, but more of a localized issue. So this patient was an adult. He was much older actually, so he's around 75. So he had a fractured upper left first bicuspid at gingival level. And I was asked whether I could extrude this root orthodontically in order to permit post and core placement and ultimately actually a fixed 3-unit fixed bridge replacement of the upper left second bicuspid. Okay. Now this patient actually was a father-in-law of probably the best dentist that I know. And this is not simple orthodontics to do, okay? So when we were doing this, what I asked for was for a core to be placed in the upper left first premolar, like you see in the photograph here on the lower left. What I've also asked for actually is for a window to be cut into that core so that I can place my attachment quite snugly into that area. Okay, why do I do that? Well, I do that because it's really important that this attachment does not come off during orthodontic extrusion. If it does, unfortunately, that core and also the root, most crucially, which is bonded to the core, will reintrude very, very rapidly after that bracket debonds. Okay, so therefore, we just want to do our best to avoid any failure of that attachment. Okay, so we've therefore used a window that I've placed my attachment in. I've extruded this tooth over a short period of time. He's had orthodontic treatment with a sectional fixed appliance over around about 4 months or so. We successfully extruded the tooth, and that's great, okay? However, our challenges don't end there. So the next thing I will be asked is, well, Porrick, when can I move on to the restorative phase? When can I place my bridge, okay? Well, I will say, actually, the honest answer is I don't know based on research. We just don't have the answer to that. But what I do know is that these lone extrusions are very, very, very unstable, okay? So therefore, we need to look at an interim period of retention before we move on to that restorative phase of treatment. So I'll try to caution patients to avoid jumping into that restorative phase of treatment. Now, although we will only remove the bonded wire during the restorative phase temporarily, there is a risk that that tooth will reintrude. How do we prevent it? Well, in this case, what I've done is to place a sectional bonded retainer here in the upper left canine first premolar region. And what I've also done is to place a rounded button buccally on the maxillary left first bicuspid so that I can engage this within a very flexible vacuum formed retainer, again, to give kind of a dual effect in order to maintain this extrusion. It is inherently unstable, okay? Now, ultimately, we left this patient for a period of around about 4 months or so before he went on to have his fixed bridge. And fortunately, he did not experience any relapse over that time period. Okay, but a real challenge. So finally, let's look at gingival response to tooth movement. We've shown you some examples, but let's try to explore it in a little bit more detail. Now, the first thing that I would say is that we have different requirements depending on the presentation. In some patients, particularly those who have subgingival fractures and subosseous fractures, what we might want to get is extrusion of the tooth, but less movement of the supporting bone in particular. Okay, so how do you avoid movement of the crestal bone? Well, it is difficult. Okay, some would say by moving teeth more rapidly, you're less likely to get this movement of the bone in particular, but that's not fully predictable. What else can we do? Well, in theory, we can do things like fibrotomies, regularly. Certainly there is animal-based research to suggest that this may be effective, but human studies in this, I have to say, are lacking, okay? We look at a case where we might need this type of intervention. So this was an adult patient, class 1 occlusion, again, previous orthodontics. Now, she had planned orthodontic treatment with me simply just to align her teeth, upper and lower. Unfortunately, prior to committing to orthodontics, what happened was she very unusually had a subgingival fracture on the mandibular left canine. Okay, so you can hopefully just about see a Kray's line here. You can see some gingival inflammation lingually, and that fracture was subgingival on the lingual aspect. So what could I do here? Well, basically, given that she was planning orthodontic treatment anyway, and had provisionally been planned for an implant to replace the mandibular left canine, between the periodontist, prosthodontist, and I, what we suggested is that maybe we should try to extrude this lower left canine orthodontically, possibly to avoid the need for an implant, but certainly to reduce or obviate the need for bone grafting if this patient is indeed to have a dental implant. So therefore, again, we'll undertake some sequential extrusion of this tooth. What you'll notice is that I'm reducing this temporary core as well sequentially during the process to remove any occlusal interference to this tooth movement. So again, hopefully you can see, reflected in the gingival margin movement here, a really significant amount of extrusion of this tooth. Okay. Ultimately, this then permitted, a more predictable restoration of the tooth. Okay. Again, just in the previous case though, this is very, very unstable tooth movement. It's a lone extrusion. So therefore what you'll notice I've done during the retention phase here again is to try to ensure that I've got a good bonded wire here, which in this case can brace the distal tooth here to maintain that extrusion a little bit more predictably. Okay. And again, I will caution against jumping into the restorative phase too early in this particular patient. Okay. So again, we will slow down that process, and that is important. Another example here. So this was again an adult patient, one who'd seen dentists over the years, previous orthodontists as well. They'd all suggested this upper right central incisor was ankylosed, and I can see why they thought that. There was previous trauma, okay? However, I would suggest that if you're assessing for ankylosis, please do check for physiological mobility, not just percussion. If you imagine if you percuss that tooth, it's longer, it's got composite, your hearing may or may not be good. Quite often it is difficult to recognize, that higher percussion tone. Okay. So therefore I would always assess from mobility, physiological mobility of these teeth as well. Now, when I did that, I actually found that this tooth was not ankylosed. Orthodontic treatment was possible, and this idea that had been suggested around vertical bone grafting and implant replacement around that upper central incisor just wasn't required. So therefore I've sequentially extruded the tooth, and you can see the gingival response associated with that tooth movement. It is pretty faithful. It moves fairly well. Okay. It is not, however, necessarily going to be one by one, particularly in patients with thinner periodontal phenotype. Now, one thing that you might notice here in the lower photographs is that I'm actually trying to intrude the upper left central incisor somewhat here as well. So I've got a wire bend in that upper left central incisor to move that tooth upwards. Why am I doing that? Well, I'm doing that for two reasons. One, because I want to improve the gingival aesthetics between the central and lateral incisor on the left side. I want therefore to want to move that gingival margin in the left central incisor higher relative to the lateral incisor. But secondly, I know that if I intrude the upper left central incisor more, I don't need to extrude the upper right central incisor quite so much. So maybe the tooth movement as a whole might be just that little bit less unstable. Nevertheless, this is very, very, very unstable treatment. Not because the orthodontics is poor, but just because the presentation itself was so severe. Okay. So therefore, again, I will want to try to dissuade this patient from jumping into the subsequent restorative phase of treatment too early. How will I prevent them from doing that? What I do, even as an orthodontist, is I try to do some bonding. So I've done a little bit of bonding to the edge of the upper left central incisor with direct composite. I don't charge the patient to do this, certainly. I just feel this is my duty to them in order to get what I feel will be a more stable outcome potentially. So I'll do some interim bonding. I will leave this in place. And again, hopefully we can persuade the patient not to have that crown replaced on the upper right central incisor for a little while. Why is that? Because when they do have the crown, unfortunately, we're going to have to remove the bonded wire temporarily from that tooth, and there is a risk of reintrusion, even if it's just being carried out over a period of 2 to 3 weeks. Okay, so we need to be careful, and we therefore need to be patient. So another example here. So this is a patient who had a restorative only solution to what I feel was an orthodontic problem. So if you look at the photographs on the left side, you'll see what I think was the thickest veneer I think I've ever seen. Okay, this was on the upper right central incisor. It was a composite veneer. Now what to look at here in particular is the height of the gingival levels. Okay, now this patient had been planned for quite a bit of restorative treatment following orthodontics. Okay, and included within that was going to be some surgical gingival recontouring. So what did I do? Well, basically, we had a discussion around what would be possible orthodontically. I felt I could align the central incisor relatively easily, actually. So what I did was some incremental reduction on the buccal aspect of that veneer prior to commencing orthodontics. The reason I did that was because actually I did this with clear aligner therapy, okay? So I got the patient to the point that you see on the right-hand side of the slide here after 6 months. Okay, so the alignment's definitely improved, but there's still a buccal-lingual discrepancy. Okay, so we then iron that out by making our own in-house aligners. It's just a more efficient process for me to do that. Okay, so we undertake the final bit of alignment with that. Okay, now what I also do again in this patient is to do a little bit of bonding to the incisal edge of that upper right and left central incisor, actually in this case, again to try to improve the appearance of these teeth on an interim basis. Why do I do that? Well, I do that in particular because actually it is important that we leave some time for recovery in terms of the gingival architecture around that upper central incisor. So the photographs that you're looking here at the right side are actually 3 months following orthodontic treatment. I arranged for a recall appointment with this lady to assess the recovery of the gingival appearance because I felt that actually when we removed that plaque stagnation area, that hypertrophy that built up around that central incisor would improve naturally without the need for gingival recontouring. So that's actually what happened. Okay, so we've saved this patient, I think, quite a bit of intervention that she would otherwise have been subjected to. Okay, so she had no gingival recontour. Now, can we improve the gingival appearance during the restorative phase of treatment or even during retention? Well, I think we can help our restorative colleagues. So you look at an example here. This is a patient who had previous orthodontics. We relocated space for a prosthetic replacement of this upper lateral incisor. In this case, as it was an adolescent with an adhesive bridge. They also had some space redistribution for buildup of the upper left lateral incisor. Okay. Now what we've done here actually is to modify the Essex type retainer. So if you look at the pontic here, we've actually got a projection. So we've placed some restorative composite on this pontic. We then get the patient to wear this for a period of around about 2 to 4 weeks. What it's doing is it's essentially sculpting the soft tissues. So we've got a slight excess of composite material here. It's impinging. It's important to say on just the soft tissues, not on the bone. Okay, so it's hopefully going to allow full seating of the aligner or of the retainer, but also place sufficient pressure to get some gingival recontouring. So we do this restorative composite, as I said, over a 2 to 4 week period, and it can result in some very nice resculpting of the soft tissues so that ultimately we can get a more favourable emergence profile. So we can help our restorative colleagues. One final case to show you. So this is a 56-year-old female. Okay, so she had an unsightly crown affecting the upper right central incisor. She otherwise had a class 1 malocclusion, a little bit of mild lower arch crowding. So we can deal with the orthodontic issues. That's just not a problem. Okay. However, she also had a subgingival fracture in the upper right central incisor. She had some recession on that tooth as well. She had a high smile line and she had quite a thin periodontal phenotype. Okay. So what would we aim to do for her? Well, again, we come up with agreed aims. We would try to ensure that she's got realistic expectations of treatment. So we'd align the arches. We can do that fairly predictably. We thought that we would facilitate a replacement of that indirect restoration, the upper right central incisor, but we would only try to attempt to improve gingival harmony. I knew there was a good chance I would not be able to fully correct this despite our best efforts. She would therefore see a group of specialists. She, in this case, did have root canal treatment, but she also was booked in to see a periodontist, basically to counsel her around the likely predictability of any redraping of the soft tissues that might occur associated with orthodontic treatment. Basically, I felt that I mightn't fully correct this, and actually she might benefit from some gingival grafting if I don't fully get this right. Now, in this particular patient, she did have a temporary crown, okay? And she had a temporary crown placed because essentially we had to do that. Why was that? Well, she was having her retreatment retaken. She had a new post-core crown. So actually, or she had a new post and core, and ultimately, therefore, prior to the definitive crown, it made sense to use a temporary crown. Now, I get slightly worried when I see temporary crowns in place, particularly when I'm extruding teeth. Why is that? Well, it's because when we're extruding teeth in particular, what we do not want to happen is debonding of the temporary crown, because if we do cause debonding, unfortunately, that crown will be held with the bracket in our appliance. Meanwhile, the root itself will not be extruding with our as we hold the crown, and similarly might actually be reintruding quite rapidly, unbeknownst to us. So it is very, very important that we apply light forces as we do this, that we don't risk debonding of these attachments. And therefore, genuinely, this is a very incremental process of extrusion. So we'll gingivally bond the attachment, we'll distally incise the ledge to maintain the aesthetics as we do it, and we will incrementally increase the bends that we're using here in an effort to incrementally change the tooth position without causing decementation of that temporary crown. So ultimately here we get to a point where the teeth have aligned, we debond the patient and she has her definitive restoration undertaken. Again, I'll be asked, well, how soon do we undertake that definitive restoration? Again, I will be honest and say that I really don't know. It is, however, a lone extrusion, so I would suggest a minimum period of 4 months or so before proceeding with that restorative phase of treatment. She will then have a bonded wire replaced on that tooth because, again, reintrusion unfortunately can happen over time. So that patient had improvement in the gingival position. She did not have full correction. Okay, so how predictable is this gingival response? Well, I would say in particular, in a case like that with thinner periodontal phenotype, you just have to look at that upper right canine here. She had significant recession. Okay, when we're extruding teeth, I do think that faithful extrusion of the gingiva in these patients with thinner phenotype is not necessarily faithful. So you've got to expect that the gingiva will not move fully. With thicker phenotypes, extrusion is much more likely to be predictable. I've shown you a number of examples of that earlier. On the other hand, with thicker phenotype, or, in particular, when we're intruding, there may be a risk of some bunching of the tissue as we intrude. Okay, so again, you just need to be mindful of that. Now, if we look at some of the cases that we've treated, as James Vaden suggested, around self-appraisal, hopefully we've got some nice outcomes in many of these cases. However, I have accepted compromises, and they were premeditated compromises that hopefully our patients were fully aware that we were going to make. In particular, I accepted some lower midline shifts. I accepted a gingival margin discrepancy as well in one case. And I think that they were the right compromises to make in those particular patients. So I would say in conclusion that it is a truism, but risk and benefit is something that we have to consider, in particularly in adult patients, in whom I think there is a higher risk of iatrogenic damage during treatment. Every adult patient is very different, and therefore I think it is important, again, when we're trying to balance risk and benefit, that we do have very tailored aims and objectives for our treatment. And these should encompass not just the outcome of treatment, but also the process of treatment itself. Now, finally, I would like to mention just one course that I run myself. It's a Zoom course through my Facebook group, Orthodontic Fundamentals. We've got a course taking place in around 6 weeks' time. And if anyone is interested in attending, please do contact us and indeed follow us on Instagram or Facebook. So thank you again, and I'm more than happy to take any questions if they do come through. And I know Valeria here will send any of those questions through to me. At this stage, I don't see anything coming through. But as I said, I'm more than happy to ask any if there are any. I've just messaged Valeria as well, just to see if there are any questions. She is currently checking for questions, and she's advised that there are no questions in the chat. So, on that basis, I would again like to thank you all for attending. I hope you found this session useful, and obviously look forward to seeing you all at some point in the future. Thank you again. Take care, everyone.